Hello everyone, I welcome you all again with another video. And today I want to do Odell case number 34. It is the case name is the a sore mouth. Uh, I want to do this case because recently today only we have done the lichen planus topic, and I just want to show you that you will learn in detail in this case, okay, about the details of lichen planus, detail of lichenoid reaction if that happens. So this is just an overall idea from Adele, and as this is UK based book, so the management that you need to follow is from the TG. The management was like we are referring the patient to the specialist, okay, because it has the potency to turning into malignancy, or it is associated with increased risk of getting the transformation done. So we are referring, but here the management might be still bit different, but you would learn more things from this chapter. So we will start. So here the Afro-Caribbean woman, which is she is 55-year-old, she presents to you with a complaint of a sore mouth. So now she has the symptoms. Okay. You must make a diagnosis and institute treatment. So this is the picture that they have given. So what you can gather from here, like this lesion is happening on the buccal mucosa. As we read in TG, that the buccal mucosa is the common site for the lichen planus to occur. And secondly, can you see this reticular pattern? This white color reticulars, white striations happening. So this could be, this is also a sign of lichen planus, but it could be lichenoid reaction as well, or any other uh, disease like lupus erythematosus. So we will read in detail how we can exclude them, and we can like make sure like what the condition actually is, like which investigation we needs to do. Okay, so first we will start with the history. So here the patient complaints was a patient who complains of occasional soreness on the inside of her cheeks and white patches on the inside of her lips. So there is from these lesions, and this is the inside of her lips. She is experiencing occasional soreness, and these are the white patches that are present that is bothering her. What is the history of present complaint? Patient noticed a burning sensation 3 months ago, and she notes that the soreness is brought on particularly when she eats sour and mildly spicy food. That's what we read in TG, that if there are two forms of lichen planus, one is the non-erosive and the erosive. Erosive form is bit more symptomatic, but the lichen planus can show the symptoms if the patient does have sour or spicy food. She had noticed that the white patches on her lips started around the same time, and she thinks these patches are spreading. Okay, and you checked her medical history. She's fit and hell. Sorry, not hell. She's fit and well. And she's not on any current or recent medication. She has never smoked and consumes less than 5 units of alcohol a week. So her medical and social history is nil. There is nothing significant. Then what? So you have taken the history here. So now you need to start your examination. First you will start from extraoral. What you will look in extraoral, you will check fit and appearance, which is well. There are no rashes on her face, because we know that lichen planus is a systemic disease, and that does affect your skin, nail, hairs as well. So we can check those things. So there are no rashes on her face, no cervical lymph nodes are palpable, and the white patches were visible on the upper lip. Then inside her mouth, the mouth is well lubricated with saliva, and the patient has good oral hygiene. There is no discoloration of the occlusal surface of the lower posterior molars, and only minimal occlusal amalgam restoration. Why they have given this line here? Because they want to exclude it from the lichenoid reaction that we read in TG, that the lichenoid reaction is the contact hypersensitivity that happens in contact with the dental restoration, mainly the amalgam. So in this case they stated that patient has an amalgam restoration, but that is only in the occlusal area. It is not associated with and is not in contact with any mucosa. The appearance of the upper left and right buccal mucosas are shown, sorry, in figure 34.1, and of the palate in 34.2. So here the appearance is shown. Describe what you see on the buccal and palatal mucosa. The buccal mucosa is affected bilaterally. We can see left and right, both sides are affected. Okay, and associated poorly defined diffuse brown pigmentation found mostly at the periphery of the striation. So there are some brown discoloration as well. Okay, the white striae extend from the posterior buccal mucosa to the commissural area. In the left buccal mucosa, there is a central solid patch of white mucosa, and the poorly defined striae are seen in the right soft palate, like here. Okay. In the right buccal mucosa, the white appearance of the buccal mucosa is most prominent in the occlusal plane. There are no obvious red patches and no ulceration. Okay, so what is your differential diagnosis? What, after taking the history, after taking these pictures, what is coming into your mind? What is your provisional diagnosis or differential diagnosis? First one is lichen planus. Second one, it could be lupus erythematosus. And third one, it could be lichenoid reaction. Then justify your differential diagnosis. The combination of radicular and diffuse white areas on a background of slight redness almost certainly indicates one of these three conditions. Okay, the lesions cannot always be diagnosed by their clinical appearance alone, although there can be some differentiating features to each condition. First one is the lichen planus. This condition is the commonest of the three possible diagnoses and most prevalent in the women and in the age group, which is the fifth and sixth decades of the life, which is completely suiting our patient. The striae and lacy patterns on the buccal mucosa are distinctive of lichen planus and are typically bilateral, because lichen planus happens bilaterally. And lichen planus can also cause white patches on the lip and palate, as in this patient, although this is less common. Like we read, the tongue, buccal mucosa, and gingiva is the common side. In this patient, it has happened on the lip, although it is rare, but it could happen. Then the second differential is lupus erythematosus. The mouth may be involved in lupus erythematosus either as a part of systemic or discoid. In both conditions, clinical features of oral mucosa resemble those of lichen planus and lichenoid reaction, but some findings may help in diagnosis. So, lupus erythematosus is more frequent in female and has a higher prevalence in Afro-Caribbean, like the ethnicity which our patient belongs to. Lesions in LE often have a central ulcer or erythematosus area around which the striae tends to it's just like a, you know, like sun-like appearance. I will just draw something here. Its its appearance is like that. So here is red discoloration or a red central area, and then the striae are radiating in a random pattern, like this. So this is the characteristic of lupus erythematosus. Okay, then the lesions are also typically asymmetrical and affects the hard and the soft palate, which are less frequently involved by lichen planus, because in this patient, sorry, The soft pellet is also involved, which is not very commonly involved in lichen planus. So we can also, like, due to certain findings, we can put erythematosus in our differential diagnosis. LA is much rarer than either of the other two possibilities, but unilateral involvement of the palate and the lip involvement, as well as the patient's ethnic background, indicates that LA should remain a consideration in this case. Then the lichenoid reaction. Oral lichenoid reactions may be localized or more widespread. So we know, like, these reaction, if they are happening due to localized cause, which could be the localized cause like any restoration, okay, or it could be systemic. How could the systemic can happen, like due to any drug, which we read in TG, which are mainly the drugs which helps in lowering down your blood pressure, NSAIDs and thyroid related drug. Any patient who has a medical condition like hepatitis C virus infection or thyroid disease, so it could happen as localized or widespread as well, in which case they are usually caused by medications. Some features that points to a lichenoid drug reaction rather than lichen planus include acute onset, extensive ulceration, asymmetrical distribution, and severe involvement of the dorsum of the tongue. So these are the things that are indicating towards lichenoid reaction. The lesions may also affect sites that are less commonly affected by lichen planus, such as the floor of the mouth. Lichenoid reactions may be clinically indistinguishable from lichen planus. In this case, a lichenoid drug reaction can probably be ruled out because the patient is not taking any medication. Although double checking recently discontinued prescription or over the counter drug is necessary to be certain, because an NSAID could also leads to these type of reactions. So we need to check these things again with the patient, but the patient in medical history stated that she's not taking any medication, so we can rule it out. But the location and the distribution of the lesion do not correspond to any dental restoration, so a topical like no reactions can be ruled out. How do you explain the darker pigmentation? So it is called inflammatory or post-inflammatory pigmentation. So the melanocytes, which are the cells present in the epithelium, which helps in giving the pigmentation, they get deposit there and they can cause this dark areas. What further questions and examination are appropriate, and explain why? Okay, so they told that you need to ask these questions to the patient. You need to ask if there is any rash, because lichen planus does affect skin, nail, or scalp problem, or hair problem, or scalp problem, and about any genital symptoms. So you need to inquire about that. Only a minority of cases with oral lichen planus or lichenoid reaction will have skin lesions on presentation. This is because the skin lesion often resolves spontaneously after a few years or with topical steroid treatment. In contrast, oral lesion may persist for many years. Okay, so you need to what you a further question you need to ask, you need to ask for any systemic involvement, like any skin lesion. Either it could be related to discoid or lupus erythematosus, or it could be related to lichen planus. You need to rule that out. Okay, or the sign and symptoms of SLE, which is, although it is a less likely diagnosis, the patient should be asked some questions to exclude systemic involvement. Like you, questioning and examination should be more thorough if oral lesions suggest lupus erythematosus by virtue of their appearance, distribution, or young age. Okay, then what is the investigation that are needed is the biopsy. So you need to do biopsy, and according to TG, we won't be doing any biopsy. Who will do the biopsy is the specialist. Which specialist? Oral medicine specialist. Which part of the lesion would you remove? This is the specialist thing, but just for your knowledge, you can just learn. It should be elliptical, about 8 to 10 millimeter long, 5 to 6 millimeter wide, and then even 3 to 4 millimeter deep. Okay, and what other investigation would you perform? So there are some antibody screening. You can do it to rule out lupus erythematosus, okay, and microbiological test or any other test. So you can try doing that to these could be additional tests that you can do, but biopsy is must. Okay, so this is the biopsy sample that they have shown here. So this is the lower power view, this is the higher power view, and this is higher power view of adjacent area as well. So in the biopsy specimen shown, what do you see? So here they have explained the histological appearances, like the well demarcated inflammatory cell infiltrate, the band, and you all know like these do cause these immunological reaction, they do cause the splits, or they do affect the epithelium and the connective tissue, right? So these are the stages that they have shown here, although this is not very important according to exam point of view, but you can have a read about this histological changes. Okay, and how do you interpret? So the dense band of band like infiltrate of lymphocytes, so the dense band of lymphocytes and lymphocytic infiltration of the basal cells with focal basal cell degeneration, apoptosis, loss of basal cells, and a thickened basement membrane are typical of lichen planus. So, if there is any lymphocytic infiltration and the apoptosis, degeneration, loss of basal cells, so these are all of the sign and symptoms of the lichen planus, which are denoting towards the lichen planus. So, after performing the biopsy, we have confirmed that the diagnosis is lichen planus. Then other results, in this case the auto antibody screen results was negative and no candida was found. The full blood count as well as the hemolytic and so these are the tests that they do in UK. They can do as a general dentist, but here in Australia you just need to refer the patient if you are suspecting any oral lichen planus in that patient. The diagnosis, which is your final diagnosis, is the lichen planus with oral and cutaneous involvement. What treatment you need to prescribe? So this is also according to UK, which they are prescribing here, like because the patient has symptom, so we are prescribing him topical benzidamine or topical medium potency corticosteroid high potency. But in TG we read that as a general dentist we can only prescribe mild corticosteroids, not even medium or high potency. And on top of that, if there is any, we are suspecting the lichen planus, then we are just referring the patient to the specialist to perform the biopsy, and he will review the patient continuously because there is a risk of oral malignancy. Okay, so here are some treatment options that they have given, but this is not very important as a exam point of view. But this case do give you some overall, idea of lichen planus, lichenoid reaction, and some important insights about the diseases and how to make the differentiation amongst them. Okay, so this case is done here, and all right, so thank you so much for watching my video, and I'll see you guys in the next video. See ya.